and thank you all for attending today and for having me at this webinar. Before I get started, I wanted to say a little bit about language. So throughout this presentation, I'll generally be using identity first language and referring to autism as, autistic adults or autistic older adults. But when I talk about the diagnosis of autism spectrum disorder, I'll say people who are diagnosed with autism spectrum disorder. And I do this to align with community preferences and the preferences of our advisory boards. So I first wanted to start by just highlighting some really important facts about autism as it relates to this presentation. So, currently, autism affects about 1 in 36 kids, or 2.75% of the population. There is really significant heterogeneity, especially in autistic adults and especially as folks age. And we've seen large changes in diagnostic practices, as well as the sensitivity of our diagnoses, which have led to cohort effects over time, as well as missed and misdiagnoses among autistic adults. And for this presentation specifically, I wanted to highlight that this is a lifelong condition, yet only less than 1% of the research that we're doing so far in autism is focused on aging. And this is related to the research funding aging research. I will say that this is a little bit outdated. We've had 2 aging specific studies funded within the last year that isn't reflected in the NIH's reports about autism research funding priorities. So in autism, we've seen this massive boom in diagnoses. From when we first began to measure autism and the CDC first began to measure autism prevalence in 2000 to today, where we're thinking of autism as affecting about 2.75% of people. Really important to this study and to the way that we're talking about aging is the fact that this group of children, 8-year-old children who were first identified in the early part of the 2000s, so they were all born in 1992. These folks are currently 31 years old. And over the next 20 years, we're going to be seeing them reach midlife and older adulthood. And we need to be prepared as a service system and as a research and provider community to be able to correctly address their needs, especially as we see these large cohorts of folks who have been identified in the last 23 years, reaching midlife and older age. So I think really important to think about is that autism is a relatively new diagnosis in the broader history of psychiatric diagnoses. So the first person ever diagnosed with autism, Donald Triplett, passed away this summer at the age of 89. And because the first person ever diagnosed with autism, just this summer reached the end of his life, we know very little about what aging looks like and what the full lifespan looks like for autistic people diagnosed in childhood. However, we do know, based on what I presented previously, that there are more adults who are identified with autism spectrum disorder diagnoses than ever before. And in addition to this, there are many, many missed diagnoses or misdiagnoses, particularly in middle-aged and older autistic adults. We do have some preliminary evidence of decreased life expectancy, as well as greater morbidity and mortality. However, at this point, we have very insufficient research on health and aging and quality of life that really limits our ability to develop supports that can support living well for the full lifespan in autistic people, as well as, that can inform advocacy efforts for autism self-advocates or family advocates. When we think about aging with developmental disabilities in general, we need to keep in mind the context that deinstitutionalization was relatively recent. So in the state of Wisconsin, we still have some of the relics of institutionalization, in that one of our long-term asylums for adults with intellectual and developmental disabilities is still open and is still housing folks who were institutionalized in their early part of the century, who are now reaching the later part of their lives. We've also seen over time, increased awareness and acceptance of autistic people and of people with intellectual and developmental disabilities. That, has led to greater community inclusion. It's led to increased opportunities, and it's led to, more access to sufficient care and diagnoses over time. And, in the United States, most of the adults with developmental disabilities in our systems receive care through Medicaid and Medicare, particularly Medicare, because that serves folks at the end of life. But also, in addition to that, many adults with intellectual and developmental disabilities receive their insurance through Medicaid. And over time, we've also seen an increase in the life expectancy of people with developmental disabilities, including autistic people. So, what might autism look like in an older adult who might qualify for an autism spectrum disorder diagnosis, but who had this diagnosis missed, right? So, this person may be a parent of a child who is diagnosed with autism spectrum disorder, who begins to see symptoms of themselves and their child. This may be a 60-year-old man who worked in tech for his entire life, but had a really limited set of friendships and social relationships. This might be, the person who is unhoused and who's had a really hard time accessing employment and services over time, or this person may be, somebody who might have qualified for an autism diagnosis, but was diagnosed with intellectual disability or schizophrenia when they were in their, teen years or early adulthood. So in general, quality of life in autistic people. So we think about quality of life as a multidimensional construct that includes domains such as emotional well-being, interpersonal relationships, including romantic relationships and friendships, material well-being, self-determination, and being able to make your own decisions about your own life, social inclusion, and rights and social justice. In autism research, quality of life has been a really increasing area of focus, and it's a high priority for autistic people and for their loved ones. In general, within the research on quality of life in autistic adults, we find that self-reported quality of life scores are lower on average in autistic adults compared to non-autistic adults. However, there are lots of autistic people who have really high quality of life, and there's a lot of heterogeneity in terms of relative level of quality of life across autistic adults. We think about quality of life really in two ways. So there's objective quality of life, which is how somebody would define another person's quality of life if looking in from the outside. And then there's subjective quality of life, which is how a person feels about their own quality of life. So in the research that I've done in my lab and that I've done with collaborators, we've found that a number of things are associated with better subjective quality of life in autistic people. And these include higher levels of independence and daily living skills, higher levels of social cognition, or the ability to understand social situations, more social engagement and more community support, lower levels of perceived stress and feelings of distress, a lack of bullying during childhood and adolescence, and then better sleep quality. So, and that's not just the amount of time you're sleeping, but the relative quality of the sleep that you're getting. In terms of objective quality of life, we found that factors such as better daily living skills, as we saw with subjective quality of life, better executive functioning, better physical and mental health are all associated with better objective quality of life. I think that important to this is that greater independence is not necessarily linked with better objective quality of life, although self-determination and one's ability to make their own choices about their own life is very important in determining objective quality of life. So the findings about objective quality of life bring us to this work on health. So we did this study back in 2016 when I was in my postdoctoral fellowship at the Wakeman Center working with Marcia Malik and Jan Greenberg. And, we found in this study that autistic adults who are physically and mentally healthy have the best subjective quality of life, even compared to autistic adults with traditional markers of, quote unquote, good outcomes. And, you know, we think about health problems as a relatively normative part of the lived experience for all people, including autistic people as they age. But, you know, the amount of physical and mental health problems seem to really be deterministic in people's relative level of quality of life. So it's important to study health, and it's important to help people live their healthiest lives in order to help them live their best lives. When we think about disparities, so health disparities in autistic people, you know, we have to ask the question, does being on the autism spectrum, having a diagnosis on the autism spectrum, lead to health disparities? You know, so as we've discussed already, there's a history of institutionalization, and then on top of that, mistreatment in institutions and asylums. You know, many autistic people are socially isolated, and lack of social support may lead to problems with health. You know, and we also have information that indicates that autistic people have poor access to health services, and specifically high quality health services. And then we'll talk about this in a little bit more detail in the next couple of slides. Heightened morbidity, meaning more health and physical and mental health problems, as well as early mortality. So, you know, I wanted to put a little bit of caution into our discussion about early mortality in autistic people. So a number of studies have found that, you know, autistic people may die 20 to 30 years earlier than non-autistic people. However, when we look at just autistic people over the age of 65, so people who have already made it to the later part of life, we find that life expectancy is much more similar between autistic and non-autistic people. You know, so it's only a 2-year difference as opposed to this 2 to 3 decade difference. You know, I think a lot of that is because we're seeing peaks in early death from things like epilepsy and accidents and suicide in the early 20s. But then we see a much more normative life expectancy for people who are, you know, middle-aged and older when we begin to follow them. You know, and you know, this study found an older age of death in autistic older adult beneficiaries than identified in other mixed age samples. But I will say that this study is fully representative of all of the autistic people in our Medicare system in the US. Now, so I want to talk about a study that we did about lifetime health problems in decedents. And decedents means people who have died. And in this study, we used a data-driven approach to identify health problems that distinguish autistic people who have died from non-autistic people who have died. And we based our work on their lifetime electronic health records. The major finding of this study was that with a machine learning algorithm, we were able to distinguish autistic people from non-autistic people with about 93% accuracy based just on their patterns of healthcare utilization for non-autism related health problems. The data source for this study, so we use data from a large multi-specialty group practice called the Marshfield Clinic that covers about 97% of the population in northern, central, and western Wisconsin. We had available electronic health records on people who had died, including 91 autistic people, and we matched these autistic people to a ratio of 1 to 68 non-autistic people. And our main question was, do patterns of diagnoses in the electronic health records distinguish non-autistic from autistic people? You know, so for those stats nerds among us, we trained a random forest algorithm to classify participants into 2 groups based on their ICD-9 codes, V codes, and E codes. The splits on each tree using the best predictor among a subset of randomly chosen predictors for each node. And then we used a 10-fold cross-validation procedure in order to train and test the model. We removed diagnoses related to developmental disabilities and mental health conditions from our model to avoid overfitting. So for this sample, you know, I want to point out here that in this autism group, we're seeing that age of death, there are peaks in the early 20s, and these causes of death are largely from accidents and suicides and other factors. And then we see another peak in the late 50s. In this sample, before we matched folks on birth year, we found a 19-year difference in life expectancy between autistic and non-autistic people. But when we matched based on birth year, we found, only about a 1-year difference or a 1.5-year difference, like in our previous study using Medicare data. So in terms of the health conditions that differentiated autistic from non-autistic people before they died, we found that in autism, there was a higher prevalence of long-term medication use, as you might expect, epilepsy, developmental problems, skin conditions, ear problems. We saw a lot of very non-specific lab tests and encounters that weren't tied to any chronic diseases per se. We saw also a lot of urinary tract problems, respiratory problems, digestive problems, motor problems like Parkinson's disease, and cardiovascular disease and its risk factors. We also found a lower prevalence of cancer diagnosis and cancer treatment. When we categorized our electronic health records into categories of comorbidities, we found that, across the categories, 57% of the categories were similar, in that autistic people and non-autistic people had similar codes within those categories and similar rates of these codes. But we did find an increased risk for several things based on these categories. And I want to point out here that we're seeing heart disease as a major issue, although we saw relatively similar levels of obesity and lower levels and decreased risk for diabetes and hypertension, as well as, again, alcohol abuse and metastatic cancer. And I see questions popping up in the Q&A, but I'm going to hold these questions until the end. There are a number of limitations to this study. So I think the first limitation when we're using any claims level data is that electronic health records data may be inaccurate or incomplete. They are data that's added to the electronic health record by clinicians during encounters, so it only represents the codes that the clinicians entered when providing care. It doesn't represent the full range of things that may be going on with an autistic person. We also don't have any true estimates of all-cause mortality or life expectancy in this study because of the limitations of the data. And, I think really important here is that there are cohort effects. So, we did have stable findings across groups, but matching was very difficult. And the people in this study were people who had died, and they therefore don't represent the current generation of autistic young adults who are living today. So, another study that we've worked on was using Medicaid data from the state of Wisconsin. And, just as a refresher for those who aren't familiar with Medicaid, so Medicaid is a state-administered anti-poverty program that provides free or low-cost health coverage to people with low income or people with qualifying disabilities and assets. The goals of this study were to describe the physical and mental health of a sample of middle-aged and older autistic Medicaid beneficiaries. And we wanted to test differences in health conditions between autistic adults who did and did not have an intellectual disability. Our sample ranged in age from 52 to 88, and about half had an intellectual disability, and the majority were men. And because this is Wisconsin, the majority of our participants were white. In this study, I think the really notable thing is that we did not find that intellectual disability is driving the high rate of health problems in autistic people. So we did find a higher prevalence of epilepsy and a lower prevalence of depression and anxiety in autistic adults with intellectual disability, but other conditions were relatively similar across the groups. Things that I want to point out here that we saw a really high prevalence of sleep conditions at about 85%. And we saw, moved back accidentally. We saw that cardiovascular disease affected about 49% of our sample. And, this is at an earlier age than we would be expecting in the non-autistic general population. And then we saw, as we might expect, higher rates of gastrointestinal disorders and neurologic disorders. This study, again, has several limitations. So, it's claims data that has many benefits, but a few limitations, including no clinical validation of diagnoses. Claims data more accurately capture chronic conditions like cardiovascular disease and less accurately capture less serious medical conditions like rashes. These data only represent people who have been identified with autism and who have health conditions that have been identified by healthcare providers. So maybe missing both autistic people who don't have an identified autism diagnosis and autistic people who have health problems that providers have not identified. I also want to note that all of the adults in the sample qualified for Medicaid, so they met asset requirements for Medicaid, which, limits their assets to about $2,000. So these big data studies that looked at morbidity or health problems in midlife and older age in autism, we found that there are relatively poor health outcomes across the board. And health may differ in some small ways by the IDD type, so autism for alone versus autism with intellectual disability and the subphenotype. We don't know many things, including what predicts positive health outcomes or mortality, what the effects are of social policy benefits like healthcare benefits and disability benefits and the environment. And we also don't know much about the effects of poverty or racial disparities in autistic people based on these studies alone. The really big gap is the question of why is this happening and what can we do about it? So this next study I'll be talking about is a study that we're working on right now in my lab. It's not published data, but we're working on writing up manuscripts for this study that looks at autistic adults' experiences with health and healthcare. So for this study, we wanted to understand how middle-aged and older autistic adults experience health and make decisions about how and if to interface with the healthcare system. We based this study on the assumption that autistic adults experience their health and access healthcare differently, which may help to explain poor health outcomes among middle-aged and older autistic people. We recruited autistic people who were age 35 and older, who had an administrative or professional diagnosis of autism spectrum disorder, who were able to communicate in English, communicate verbally in English, although we would have included autistic people who use communication devices to communicate. We didn't have any adults who use communication devices enroll in our study. And, in this study, we did include autistic adults with and without intellectual disabilities who were able to communicate in English. With our autistic adults, we conducted one-on-one interviews with 15 autistic adults. And then we asked all of the autistic adults who we interviewed to help us identify somebody who they would call their emergency contact or a person who would help them in some way with their health or healthcare. And that might be a mom, a sibling, an aunt or uncle, a spouse, an adult child, etc. In our semi-structured interviews, we probed experiences with health and healthcare across 4 domains, including health habits, health problems, health services, and autism and aging impact. And we used analytically conventional content analysis. We transcribed and analyzed our interviews consecutively, and then emerging themes were continually tested against the data. I'm going to right now present our preliminary data on, and our preliminary findings about our themes that emerged and provide you some quotes that come from our participants about each of these themes. So, in terms of the conceptualization of health, so autistic people conceptualize health as essentially the absence of pain, illness, or injury, and a lack of sensory changes within the body. So the lack of sensory changes was really important and was different in the way that autistic people conceptualize their health and their emergency contacts conceptualize health. And, for all of our participants, health and being healthy were inclusive of both physical and mental health, not just physical health. So one participant said being able to get through the day and not having anything that really gets in the way of your daily functions or daily life or causes any major pain or hardship. Another participant said, pain can feel like on the 1 to 10 scale, it can feel like a 6 or 7 to me. But as far as experiences of neurotypical people go, it's really only a 2. In terms of decisions about healthcare utilization, the autistic adults and emergency contacts in our sample did report that autistic people are utilizing regular preventive care. The decisions, though, about when to utilize care for acute pain, illness, or injury are far more difficult to make. And decisions about care utilization become really hard when things don't go according to plan. One participant said, when my body changes the way it's working, then to me, that feels like a medical emergency. And this relates to this idea of sensory changes within the body, right? So when the body changes and the sensory experience of the body begins to feel different, that's a medical emergency to this participant. An emergency contact told us about an experience that their loved one, their autistic loved one had, and said when the paramedics arrived, the participant was non-responsive and no one had any idea what was wrong with him. There was no clear sign that anything in particular was wrong. The participant hadn't been complaining about any pain or anything, but he was literally, he had gone into shock, right? And he could have died. So as they were disrobing him at the emergency room, they noticed the bruising on his shoulder, which turned out to be from a broken shoulder, which he now has a partially replaced shoulder joint. But he also had aspiration pneumonia because he also had a big hole in his tongue. And then they did a bunch of blood screenings and things to kind of look at what else was going on in his system, and he had extremely low sodium. So for this participant, a broken shoulder turned into a medical emergency because of decisions about when to seek care if things are going awry. Another emergency contact said, he manages all his own medication. He orders and refills all his meds and picks it up and everything. I never have to think about that except if something goes awry. Like some expected renewal doesn't get done, or in one case, he takes Ritalin and there was some law change that prevented him from getting the quantity of Ritalin that he was used to getting. And that just absolutely threw him for a loop, and somebody else had to get involved because there was a lot of detailed communication about what do you do next that was not the typical day-to-day stuff. And so we got involved and it got taken care of, and now everything's fine again. But life is full of unexpected stuff. And unexpected stuff just throws the participant for a loop all the time. Another theme that we identified was communication. So for this theme, we found that autistic adults and their emergency contacts told us that care providers often do not understand how to talk to autistic people clearly and with sensitivity to the autistic experience, which I'm sure is not a surprise to anybody listening to this webinar right now. And also that preparing to communicate with a healthcare provider takes a lot of preparation and energy. One participant said, I would say that their approach is not person-centered and not tailored to me, and it's not effective based on the evidence that I see. Another participant talked about the really long struggle that they had with finding a provider and said it's practically impossible to find a provider who's flexible. I finally have found one who's a chiropractic neurologist who has enough of a framework and has a way to work directly with the body that he doesn't require us matching our words in order to find the right treatment. So our autistic adults and emergency contacts who we interviewed, also brought up themes around independence. So autistic adults in general are striving to be independent in accessing and utilizing healthcare services, which, makes a lot of sense, especially considering how autistic people's rights have often been taken away from them in terms of accessing their healthcare and making decisions about their own health and their own body. However, our emergency contacts highlighted the importance for all adults, not just autistic people, but all adults, of receiving support from loved ones while managing health and healthcare. On a personal note, I know with my parents, who have been married for almost 50 years, that they are both, there at all of each other's doctor's appointments. And that's a relatively normative part of growing older for most people, is having a support person join you at doctor's appointments. But that's often something that's really difficult for autistic people to access, given the lack of social support that many autistic people experience. And, it may mean that they don't have anybody to help them. And, as a note, less than half of the autistic adults who were in our study had an emergency contact who they could get in touch with to help them if they had an emergency or they needed a support person with them when they were engaging with the healthcare system. An emergency contact told us if they need certain types of supports, it's a sign of strength to ask for those supports. Another emergency contact noted, in an ideal world, the healthcare providers would recognize, based on his autism diagnosis and interaction with him, that they will not have productive meetings with him and they will require support and help him make sure it gets set up. And also, in this ideal world, the participant would realize how important it is for these situations to have someone there to support him, not because he's weak, but because he's strong and knows that this is what he needs to be successful and take control of his life by making sure that he has the support he needs in situations that are potentially problematic. The autistic adults in our sample also noted that executive functioning can lead to a lot of challenges with health management and healthcare access. So specifically, challenges with time management, planning, organization, attention, and self-inhibiting can make maintaining health habits and accessing healthcare very difficult for autistic adults. In addition, using the executive functioning skills needed to make it through a regular day is often exhausting and makes maintaining quote unquote robust health difficult. I think I want to say here that I think a lot of clinicians and a lot of autism researchers assume that autistic people don't know what they need to do to take care of their health. We've found that that's not true, and that it's really that these executive functioning difficulties can make engaging in all of the behaviors that we're supposed to engage in to support robust health incredibly difficult. One participant said, if I had more capabilities with executive functioning, I would not have the inertia that kind of prevents me from playing a more active part in addressing my health. Another participant stated, it's not necessarily that I don't have enough time. It's that having both the time and the energy and focus at the same time, the same period, is difficult. And things like repeated task switching, it takes longer for me, so that's eating up time. So I, in principle, have the time in many cases to do something else, but the ability to then engage in what I'm doing doesn't feel like it's there. I kind of have this sense of being perpetually behind on at least personal goals, occasionally more important things to do. And so to be able to have all of that on my plate and then to try to make time for other kinds of exercise, other sorts of general activities, that kind of stuff, feels very difficult on top of not having a lot of energy left over for that kind of thing. I know that doing more exercise would likely help me upregulate my ability to have energy and things along those lines. That's part of why I'm keeping interest in doing so. Well, in practice, that has been very difficult. So there are a lot of conclusions that we could take from this study, but I want to highlight a couple of them. So first, autistic adults have sensory, communication, and executive functioning differences that impact their health and their engagement with the healthcare system and with managing their health. In addition, accessing healthcare is an area in which autistic adults often want to be fully independent, yet full independence in accessing healthcare is not feasible for most adults, including autistic adults. And finally, providers can encourage autistic adults to identify ways to partner with loved ones to access healthcare while maintaining their independence and their choices about their bodies and their health. So in terms of the work that I presented so far, this is the end of what I'll be presenting on the work that we've done. I'm going to talk about some implications and then talk about what we're doing next and what's on the horizon in the work that we're doing. So in terms of policy implications, there are, very high human costs and also monetary costs to autistic people, to their loved ones, and to government programs like Medicare and Medicaid. In addition to this, providing adequate care will be much more complicated, intensive, and costly as these growing cohorts of autistic people age into midlife and older adulthood. We know that autistic adults experience marginalization within society more broadly and within the healthcare system more specifically. And, I think importantly, we need to ask ourselves, should independence be the goal of services? Or should part of our services and part of our supports be geared towards helping autistic people establish meaningful, supportive communities that can help support them as they age, and, help support them living their best lives? There are a number of supports that can encourage healthy aging, including inclusion in social recreation and leisure activities. We can support families in planning for care transitions as parents age and as autistic spouses age or autistic parents age. We can help provide folks with housing, independent living, family living, and then as people get older, skilled nursing and assisted living care. In terms of health, preventive and routine care are important. But a part of this, that we found is that autistic people are really receiving preventative and routine care. However, the quality of that care may not be great given the difficulty that providers have with engaging with autistic people. So, and, like all adults, autistic people do need to be physically active to maintain health as they get older in a way that works well with their bodies and their neurology. And then, there also may be something in the future that we will find in terms of disability-specific risks and accelerated aging that may necessitate early screening for some or all health conditions. Just as a reminder, for all of you on the call, it's, really important to establish the correct permissions and legal documents to help ensure that people are able to help you with managing your care as you get older, including a medical power of attorney, a mental health power of attorney, if that's applicable, an advance directive and living will, and then having permissions on file with your providers to allow trusted people, maybe a spouse or a best friend or a family member, to access your medical records and be able to help you manage your care. And then I think really important to think about is advocacy. And the necessity to advocate while we work on changing physician behavior and the system. So know what preventive care you should receive and ask for it. Request sensory and communication accommodations. We want to be aware that autistic people may experience pain and illness differently and that may need to be communicated to providers. And, then also insist that providers see more than the autism diagnosis. Sarah Luderman has this concept called behavioritis, which Sarah defines as inappropriately placing importance on a person's behavior or on their autism and not on their health or medical problems. And, then I think something also very important to keep in mind is that changes in behavior or mood may be indicative of a medical problem that needs to be addressed and not just changes in autism or mental health symptoms. And I want to thank the advocates who have contributed tips over time to this work. This cartoon, I think, says it nicely. So the physician has to learn about thousands of diseases, but we as people only have to focus on fixing what's wrong with us. So which one of us is the expert, right? We're the expert on our own health and on our own bodies. So what are we doing now to, advance the field and what's coming in the work that we're doing? So we were lucky enough to have an Autism Center of Excellence Network grant funded by the National Institute of Mental Health. The people who are leading this grant are Janet Lanehart, Andy Alexander, and Brandon Zielinski. And in this study, we're recruiting a cohort of 325 autistic and 225 non-autistic adults. And we're following these folks over time, hopefully over the next 15 to 20 years, to measure and evaluate age-related decline between autistic and non-autistic adults, to investigate the relationships between clinical health and brain imaging measures in autistic adults, and then finally to collect whole blood specimens for all consenting autistic and non-autistic adults to the NIMH repository and genomics resource for future genetic studies. And I want to clarify that when I say genetic studies, I don't mean studies about the genetics of autism. I mean studies about the genetics of aging in autism. So this is not a study that's looking to find genetic markers for autism. It's looking to find genetic markers for things like early aging or health problems that present with autism. We also have a study where we're developing an autism-specific mortality risk index using data from Medicare-enrolled autistic older adults. I think something that's important to note is that the algorithms that have been created for the general population don't seem to work for autistic people. So what we're doing is we're identifying first comorbidities that differentially influence the time to mortality in autistic versus non-autistic older adults. We are developing an autism-specific index for predicting autistic older adults' risk of mortality compared to existing mortality risk indices. And then we're quantifying the number of autistic older adults at low, medium, and high risk for mortality within 2 large academic medical centers. And, we took this picture at a conference right after we found out that we were getting the grant and happened to both have our Girls Just Want to Have Funding for Scientific Research t-shirts with us. So before I end my presentation, which is right at 11:45, which I'm happy about, to take questions, I wanted to acknowledge collaborators and current and former trainees, as well as the entities that have funded our work. So, and I don't receive any, monetary benefits from any of the work that I presented today. So thank you all so much for listening to my presentation, and I am looking forward to taking questions.
Great. Thank you so much, Dr. Bishop, for your presentation. I think as you noted, you saw the Q&A chatter. So people were definitely really engaged and really interested. So yeah, we have about 15 minutes for questions. So I think we'll just jump right in with those. Sort of going back to just the beginning of the presentation, just to set the stage a little bit, what measures are you using to assess quality of life in adults?
Yeah, so, when we think about subjective quality of life, we generally assess that using standardized measures such as the World Health Organization Quality of Life brief version. When we're thinking about objective quality of life, the way that we've assessed that in the past has been looking at traditional markers of, quote unquote, good outcomes as defined by researchers, including independence in living situation, the presence of friends or romantic partners, and working in competitive employment, so jobs that folks went out and obtained on their own and not through a disability employment organization. We also included connections with friends and family. We included relative level of physical and mental health. We included relationships with neighbors and family members and the quality of those relationships. And then we looked at people's self-reported symptoms of their mental and physical health problems.
And then I guess sort of a follow-up. I know you primarily work with adults now, but you've worked with children and adolescents in the past. Is there a difference? Like, what are the differences in how you're evaluating adults versus children, or are there children that people you've worked with over the course of their life into adulthood?
Yeah, so, before I completed my PhD, I was a social worker practicing with mostly children and teenagers. And frankly decided to pursue research and pursue a PhD and begin to study autistic people because the teenagers that I was working with were aging into adulthood, and I was working on helping them find appropriate services and supports that were supportive of them as a whole person and supportive of their independence. And, we found that there really was very little research out there at the time. This was back in, 2009, 2010. So I decided to get my PhD to do work on autistic adults and specifically to study health and quality of life. to your question about what are the differences in the way that I approach adults versus children and teenagers, right? So, with as a practicing clinician, my work has always focused on self-determination and determining, where to intervene and where to support people based on their own self-reported needs and the way that they talk about their goals and what they would like to do in life and the things that they would like to work on. I think that with adulthood, the way that I approach adult clinical work is that, you're really working to help people put themselves in the right environment for success, not working to change them as a person, to change autism at all. You're really working on finding a supportive environment that supports you for who you are, as you are, to live your best life.
Great, thank you. Okay, so just switching gears here.
Yeah.
We have go ahead.
I also, there's a question here at the end about autism and marriage. Are they able to have, successful marriages? The answer to that is 100% yes. And frankly, in terms of health, in our qualitative study, we found that autistic people who were married or who lived with long-term romantic partners tended to have a much easier time accessing healthcare and a much, better grasp on their health. We know that this is the case in the general population, that people who are married tend to have, a better support system for their health as they get older. So it makes sense that that's the case for autistic people too.
Great, thank you. So just, we've had a few questions come in both in advance of the webinar and today about Medicare, Medicaid policies. And are you aware of any sort of advocacy happening around those in terms of changing the policies? So it's sort of part one. And then part two, something else that came up was, how can people, independent autistic adults specifically, how can they get help in, working with these programs?
Yeah, so, I would say, I'll say quickly that, the way to qualify for Medicaid as an autistic adult, there are essentially two major pathways, right? So pathway one is by qualifying for SSI, Supplemental Security Income, through the Social Security Administration. Once you have SSI, you automatically qualify for Medicaid on the basis of disability. The other pathway is qualifying for Medicaid just through the poverty pathway. So not based on a diagnosis, just based on your assets and your income. With Medicare, the three major ways that autistic people qualify for Medicare are: one, when they turn age 65. If they've paid into the Medicare system, everybody automatically qualifies for Medicare. Another pathway is for folks who have end-stage renal disease, so who are in kidney failure. They automatically qualify for Medicare. And then if you qualify for SSDI, or supplemental or Social Security Disability Insurance, that qualifies you for Medicare after a waiting period. With all of these Social Security Administration qualifications based on disability, folks often need to apply more than once for these programs. The first submission of the application is often denied, so certainly apply more than once. In terms of the asset cap, there is a program called ABLE accounts. I'm not remembering what ABLE stands for off the top of my head, but ABLE accounts are essentially a program for people with disabilities with childhood onset, which autism is a disability with a childhood onset, where you can put up to $100,000 in a protected account that you can use towards disability-related expenses, including living expenses. And that doesn't count towards your Social Security asset caps. So look into these accounts if you might otherwise qualify for Medicaid or Medicare, but have too many assets. And, Dominique, what was the other part of your question?
Sorry, let me just look back here. Are you aware of any sort of advocacy that's going on right now in changing these government policies?
Yeah, so, I think most of the advocacy that's happening right now is focused on protecting these programs, not expanding these programs for more autistic people. So, it's things like preventing the government from using block grants to cap funding for Medicaid. If we instituted a block grant program, what that would do is it would cap the amount of money that's given to states based on previous year's enrollment figures, which may cause them to have to reduce their amount of money that they're reimbursing for caseloads. There is some legislation that's out there that's attempting to prevent discrimination against people with intellectual and developmental disabilities in organ transplantation, like kidney disease, that's directly applicable to Medicare. But that's still in process. But, again, most of the advocacy right now is focused on preserving these programs for everybody, not necessarily changing anything within these programs for autistic people. But I think it's an area that's of really high importance, frankly, and something we should be doing.
Absolutely. Yeah. And then for those programs like ABLE, SSDI, SSI, for people who maybe don't have someone personally that's able to help these applications, are you aware of other ways that they can find help navigating the application processes?
Yeah, what I would recommend is, all states and most counties within states have these things called ADRCs, Aging and Disability Resource Centers. All of these ADRCs are staffed, they're phone call-in centers, and they're staffed with people who can help you with things like applying for, Medicare, Medicaid based on disability. And they can give you information about different types of programs that are out there. That I think would be a really great place to start. If you call your ADRC and say, I've had issues qualifying for these programs, I really need this for health insurance. Can you either give me some help or refer me to a nonprofit or government agency within the community that can help?
Great, thank you. Switching gears to just general, going into the doctor's office and receiving, the best and ideal care for someone, a person with autism. Are you, or have you noticed any shifts in the actual, the medical practitioners in their awareness of some of these challenges that autistic adults may have, and what those might be, and maybe how autistic adults themselves can meet halfway with their doctors?
Yeah, so anecdotally, I would say that the biggest change I've seen recently is not in medical providers, but in mental health providers. So I'm a social work professor. I teach a course for our master's level social work students on intellectual and developmental disabilities. And this is one of, really only a handful of courses at schools of social work around the country focused on intellectual and developmental disabilities for MSW students who will then be clinicians. We've seen a big uptick in people applying to our program because they want to be able to take coursework in intellectual and developmental disabilities. I've also seen a shift in who's taking the course, from people who were involved in school social work to a lot more people who were involved in mental health social work. I also attended a conference recently called the Integral Conference, which is a autistic adult conference. And a lot of the folks who were there were actually mental health providers who were wanting to learn more about autism. And that's a big change from previous years where we saw very few mental health providers coming to learn from autistic people. In terms of medical providers, we're beginning to see people ask for training. My collaborator, Brittany Hand, who's at Ohio State and does wonderful work, is working on an intervention right now for medical residents to teach them about autism and about treating autistic people. And it's a wonderful intervention developed by a team of autistic people on the community advisory board in collaboration with Dr. Hand. So I think it's shifting. I think that there's more interest. but we haven't, yet reached the point where we're seeing the tide turn, right? Where, right now we're in the place where it's snowballing and where, interest is growing, but I don't think that that switch has flipped to really turn the tide yet. But I think it's coming within the next 5 years.
That's great to hear about the shift and that it seems like it's on the horizon. So in, I guess, a similar vein in a way, so we have, medical providers and mental health professionals that are showing that increased interest, which I think probably bodes well for people later in life that maybe don't have a diagnosis yet and are trying to seek a diagnosis. Do you have any recommendations on resources to help an adult perhaps that's not diagnosed receive a diagnosis, and where they can start maybe?
Yeah, so that's really tricky because there aren't a ton of providers that do diagnoses. One sort of big issue in finding providers is that, so if you go online and you go on Psychology Today and look for, people who do neurodiversity affirming treatment, that doesn't necessarily mean what you would think it would in terms of their expertise, right? It's often just a box that they check to say that they want to be neurodiversity affirming, not that they have specific training. So, we've found when doing sort of community surveys and providers in the Madison and Milwaukee areas that you have to call offices and ask if anybody has specific training in, treatment or diagnosis of autistic people. And they often don't advertise that on their websites. So it's tricky. So I think that, unfortunately, the best answer is that you'll probably need to call different clinics and ask, and get information that way. If you live in the Madison, Wisconsin or Milwaukee area, you could send me an email and I will send you our resources that we put together for providers in the area, but that doesn't exist in other areas per se. It's just that we create those for our study participants as, a service that we can provide to them.
Great. And then just one last question. I think it's really exciting to see so many people that are on the call interested in participating in similar research to yours themselves.
Yes.
Any tips on how people can find out about other studies that are happening around the country and how they can get involved?
So I first want to put in a plug that we are actively recruiting for our longitudinal study in Madison, Wisconsin, Milwaukee. We could bring people in from about 2 hours away. And then we also have a site at the University of Utah in Salt Lake City. As part of that study, we can do new diagnoses for folks who have suspected autism but no previous diagnosis. And we can bring folks in for that study as well. I think that Spark is a great way to get involved in research on autistic adults. Particularly if you are an autistic older adult or an autistic older adult who has an intellectual disability. That's a really great way to participate. And then, I think, unfortunately, one of the ways that we often hear about studies is through Twitter and through folks recruiting on Twitter. So that's a good way to find it, but may not be perfect.